That's the forefoot problem. Poor fitting footwear will produce foot pain and deformity. Also, it will make their walking and running difficult. In their study, they found about 62% of children and adolescents have a long shoe, because to accommodate the wider foot, they started buying the longer shoe rather than going for wider toe box shoes. And about 60% of the children had too narrow shoes, resulting in increased deformity like a hallux valgus. There was another paper published about 3 years back from Spain. They looked at the shoe fitting and the foot health issues by a podiatrist. The harmful effects of the poor footwear will affect their health, social functioning, and mobility. They found out 90% of the adolescents and the adults have a foot problem. And they also found out only 24% of the adolescents or adults have a properly fitted shoes. So improperly fitted shoes are the cause of foot pain and disability in these children. Do we have to do X-ray to diagnose all these things? X-ray is sometimes overdiagnosed. That's why when this paper was published again about 3 years back, they found out by doing the X-ray, they ended up diagnosing more of a problem. But asymptomatic patients, you don't need any further investigations. Treated with the proper footwear, the child and adolescent, they'll do very well. So if you look at the foot disorders, it's mostly conservative treatment. Flat feet, usually in normal population we don't treat, but in a child with a Down syndrome, it's better to give them arch support with a heel cup. We call it UCBL heel cup or Helfet heel cup. And you have to make sure the toe box are wide enough to accommodate their wider forefoot. That's a special shoes. Usually if you go to the shop, you cannot get a proper fitted shoe. So always you have to go for a special shoes. If the child is symptomatic, they may end up going for a surgical correction. That's all about the lower limbs. Just a few slides about the neck and the back problem. A lot of people talk about the cervical spine instability, especially in children. The incidence is more than what we look at hips and the knees. The incidence is about 10 to 15%. The instability can happen between the head and the cervical spine or between the cervical spine. We're going very slow. Okay, I can finish. So the common age is 5 to 15 years. Most of the children are asymptomatic. Only less than 1% of the children will have a problem of spine instability. So the common symptoms we are looking for is a neck pain or a sensory deficit. Child who has a good bladder control started dribbling, or subtle symptoms like decreased tolerance for activities. Child was very active, refusing to go to play, altered gait, loss of ambulatory skills. Not going into the treatment. So again, there was a study published recently. This paper actually came from Kuwait about 15 years back. You look at the things like marked on the X-rays. The picture A, that is a dense and the atlas. There is no gap, but when you flex, there is a gap. So when you have so much of a gap, it's more than 2 to 3 millimeter gap, it starts pressing on the spinal cord. Only that time they'll develop a problem. In this paper, they found out about 18% of the adults, it was studied in adult population, about 65 adults were studied, 48 adults were studied. They found out 18% of population had atlantoaxial instability, but not everybody had a problem. And they also found out about 12% had congenital anomalies of the bone. But these adults had more of a lower cervical problem because the pain was because the lower cervical problem than the atlantoaxial instability. The next one is the scoliosis. Again, very rarely we see there are two types. One is post-thoracotomy. Most of the children who have a cardiac surgery had a sternotomy done. That acts as a tethering. That also can cause scoliosis. The second one is a idiopathic normal type of scoliosis. Usually, scoliosis, a minor form, doesn't need any treatment apart from bracing. Surgery is only advised if the curves are more than about 60 degrees. Okay. This orthopathy of Down syndrome is a very well-known entity. Recently, we see a lot of children presenting with this problem. This is almost like a juvenile rheumatoid arthritis. It involves almost all the joints, metatarsals, hips, knees, ankles, including the cervical spine. If you suspect anybody who have a joint pathology, it's better to involve the rheumatologist and start the medical management at an early stage to prevent progression of this disease. I'm not going to talk about the anesthetic issues. So in summary, about 20% of all patients with the Down syndrome experience orthopedic problems. Upper cervical spine instability has the most potential for morbidity and consequently requires close monitoring. Scoliosis, hip instability, patellar instability and foot problems can cause disability if left untreated. In some of these conditions, early diagnosis can prevent severe disability. Last slide. This paper was published from Dublin, Ireland. If you look at that, it's a simple study, musculoskeletal anomalies in children with Down syndrome, an observational study. They studied about 503 children, okay? They come out with these findings. We all know joint laxity is there, hypertonia is there, increased risk of musculoskeletal disorders there. But what this study has, if you look at that, foot, spine and hip pathologies are underestimated. That is true, like even in our country, there are a lot of children with this problem. They don't go to a doctor. They just still walk with an alternate gait or with pain. They just stay in the house. They don't go out, venture into the normal life. And children with Down syndrome are at increased risk of inflammatory arthritis. So the thing is, when you are doing an annual assessment, you have to make it a point, there should be a musculoskeletal assessment as well. This is from head to toe. Thank you.